Hello, everyone. My name is Lisa Bailey. Welcome to this live conversation titled Ending Inequities and Getting Back on Track for the AIDS Elimination by 2030. I have a panel lined up to discuss this with you, and we're happy that you've joined us on PAHO Caribbean and also PAHO WHO on Twitter, and we want you to be a part of this conversation. Now, why are we talking about this? As we mark another World AIDS Day just yesterday on December 1st, some people may be thinking, why are we still talking about this? You know, many people think that HIV or AIDS is no longer a problem. Although new infections and deaths are decreasing, we're still not close to the 90% reduction needed to end HIV by 2030. Now, this year's PAHO UN-AIDS joint campaign is based on the slogan, Ending Inequalities, End AIDS, End Pandemics. Yes, we have a new difficulty now, the pandemic, and how it has affected the fight against ending HIV and AIDS. Now, the goal is to highlight the importance of equitable access to health services and the importance of strengthening actions at the primary healthcare level, with special emphasis on HIV combination prevention and treatment services, as well as promoting work with communities to reach people most vulnerable to HIV and other pandemics. And the campaign is calling for urgent action to maintain essential HIV prevention and treatment services, even during the COVID-19 pandemic. It has certainly been weakened in some countries, but the pandemic has also taught us some lessons, and we'll discuss those today with our panel. I'm going to welcome first from UN-AIDS, Dr. James Gowani. He is director of the UN-AIDS Caribbean Sub-Regional Office. He's based in Kingston, Jamaica. We also have civil society representative Alexis DeMarco. She Executive Director at UC Trans. Alexis is a social justice and human rights advocate with a specific focus on human rights, women's rights, LGBT rights, and youth development. And we also have Director of the Pan-Caribbean Partnership Against HIV and AIDS, Dr. Rosamond Adams. And I'm going to talk to you about a statement that you made when you talked about your optimism about the region ending AIDS, but a lot of work needs to be done. We're going to talk about that. And from our own team here at PAHO, we also want to welcome Sandra Jones. Sandra Jones is HIV, STI, TB, and viral hepatitis advisor for PAHO WHO. So welcome everyone. How is everyone doing today? I hope you're doing well, and I hope you're looking forward to this discussion as we mark another World AIDS Day. I'm going to start first with you, Dr. Gowani. Welcome and thank you for joining us this morning. You know, we've talked about the inequalities associated with HIV and that they definitely needs to be changed for us to eliminate AIDS in the Caribbean and across the world by 2030. Are we likely to meet these targets, you would say?
Thank you very much, everyone, viewers and listeners, wherever you are. And, you know, I think your question is a very important question, especially at this time. After 40 years of responding to the AIDS epidemic, we now have the tools to bring it to an end. By ending AIDS, we mean that people already living with HIV should have access to the proper treatment, care, so that they live longer, healthy lives and do not die due to AIDS-related issues. It also means that we can dramatically reduce the number of people who become newly infected with HIV. Importantly, in part, we can achieve this through treatments, which is very important. When people are successfully treated with HIV antiretroviral therapy so that their viral load is undetectable, they are no longer infectious. That's why we have the saying U equals to U, undetectable equals to untransmittable. It means that not only do we keep people alive and healthy, but we prevent new infections. So while ambitious, the target is realistic and achievable. You know, by the end, let me add that by the end of 2020, we aimed to achieve the 90-90-90. This was the target by the end of 2020. 90% of people living with HIV know their status. 90% of diagnosed people are on treatment, and 90% of those on treatment are virally suppressed. In the Caribbean achieved 82, 89. That means that 82% of people living with HIV in the region are diagnosed. Of those, 82% are on treatment. And among those who are on treatment, 89 achieved viral suppression. The data tells us we need to reach more people, to reach out to more people who are not aware of their HIV status. More needs to be done to encourage people to get tested and to provide them with user-friendly options to do so, including self-testing and community-based testing. Critically for the Caribbean, I must add, 20,000 people who know they are HIV positive, but there are about 20,000 people who know they are HIV positive but are not on treatment. We must invest in interventions to provide people with care and support they need to start and stay on treatment. I think let me just conclude by answering this question, on this question to say that while we fell short of reaching the target, especially in the Caribbean, we have made incredible progress since 2015, when just 65% of Caribbean people living with HIV were diagnosed. 69% of them were on treatment and 73% were virally suppressed. We are somewhat behind the global average of 84, 87, 90, but that does not mean that the target has been unrealistic. Some Caribbean countries achieved elimination of the 90-90-90 target. For example, in Guyana, we have 94% of people are aware of their HIV status. At the end of 2020, at least 8 countries in a variety of geographic and epidemic socioeconomic settings have fully achieved the 90-90-90 target. So this is achievable. And in accordance with the new global AIDS strategy, we are now aiming for 95-95-95. Further, the goal is to achieve these results for each subpopulation, including key and vulnerable communities. And this means that we must accelerate progress by adopting and implementing key practices and community-led approaches. We must work to end inequalities and that block people from accessing HIV treatment. So yes, this is achievable. Thank you.
Well, it's good to know that we got really close to meeting that target, and I'm glad that we're close, and I'm glad that we've set a new target of 95, because I think if we could do 82, 82, 89, we can certainly strive for 95, 95, 95. So that's very good to know. There's still work to be done, and civil society is a big part of that. I'm coming to you now, Alexis, because the theme is all about ending inequities. And some say these inequities were exacerbated by the COVID-19 pandemic. Can you remind us of where the inequities exist and how can we get back on track?
Well, thank you for having me. Very good question. Civil society does play a heavy role as far as vulnerable communities and vulnerable populations are concerned. What COVID-19 has done with the major lockdowns around the Caribbean region especially has caused persons not to be able to access their treatment care and support based on government's initiatives to curtail COVID-19. We cannot lose the message of HIV based on COVID-19. We must incorporate both messages together, and we must be able to allow our communities the opportunity to have access even in a pandemic. So how do we get back on track? We get back on track with working with civil society organizations that's already on the ground, that knows their community, that's in the field, that knows their clients, and being able to work with national partners to be able to deliver meds to persons who are off track, to be able to have contact tracing, calling them and letting them know, hey, did you take your meds today? Do you have transportation to get to meds? Because we found in the Caribbean region that most people didn't have access to transportation. Even if they wanted to go and take medication, they couldn't because of the major lockdowns imposed by governments around the world, and especially within the Caribbean region. So how we get back on track is working together, working with our national agencies, working with the Ministry of Health, using the resources and using the people that's already on the ground doing the work with their clients in their community. COVID-19 is not going anywhere. We see that there's another variant. So we need to work together with our ministries of health in order to keep our clients suppressed, to keep our newly diagnosed persons virally suppressed, and also to continue testing, self-testing. We need to really push the message of self-testing. You can go now and get a PCR COVID test and test yourself. So why can't we have these opportunities available within our region that our members and our community members can be able to self-test with the on-call persons to test if they're positive, to be able to counsel, the pre-test and post-test counseling. So we need to put these things in place as a region. We cannot lose the message of keeping our people virally suppressed, and we cannot lose our target dates. So that's one of my ways of thinking how we get back on track.
I was going to ask you about the HIV self-testing, so I'm glad you went there. Do you think that expanding and strengthening PrEP can also be a strategy that could be used?
Yes, but it takes political will. The political will from governments to be able to understand that access to healthcare is not a privilege for citizens. It's their right. It is their human right as a citizen of a country. Persons involved in key population members shouldn't have to be begging the government for something that's vital to their health. PrEP is a necessity. In the Bahamas, we have rolled out PrEP, and we have seen an uptake in PrEP through Dr. Nakia Forbes' advocacy, making sure that no person is left behind. And using the Sustainable Development Goals, we need to hold our decision makers and our gatekeepers accountable to the commitments that they've signed on. We have situations in the Caribbean region where persons, decision makers are saying, no, we're not giving that community PrEP. We're not investing in that because that's going to be a moral decay of the country, you know? But again, it takes advocacy. It takes continuing to educate, because some of our decision makers and our gatekeepers don't even understand the impacts of HIV. They don't even understand the dynamics in these communities that are most vulnerable and affected by it. So PrEP, I do encourage PrEP with rollout in the Bahamas and through the Caribbean region, and I will continue to advocate for PrEP for our vulnerable community members within the Caribbean region.
Thank you so much. So well said, and highlighting some really important issues. I'm coming to you now, Ms. Jones. Now, the pandemic has posed lots of challenges for HIV services. As you've heard, restricting the availability of supplies, disrupting the delivery of services, prevention activities. How do we move forward from this? And it's been 40 years of HIV testing. So what do we need to do now to ensure everyone knows their status and advance towards ending AIDS?
Right. Thanks for the question, and good morning to everyone who joined us by Facebook. Yes, we are well into the HIV pandemic, and while testing has scaled up over the years, and people have access and have ways to get an HIV test, there are various modalities that are needed to be strengthened or expanded for individuals to know their status, especially for the key populations. And this continued to be a challenge in the region. As was mentioned by the UNAIDS, one of the first 90 target is people knowing their HIV status. While some countries may have reached and some were closer to reaching, there's still a gap when we look at the overall region. But you ask, what can we do to better ensure that everyone know their status? I want to say that integration of HIV testing into key services, rather than as a standalone service, but as a key service, but into key services, integrated with key services such as STI services, family planning, other sexual and reproductive health services, and other key services within the health system. And of course, as I think was mentioned earlier, within the HIV combination approach, and particularly within PrEP, this will help us to ensure that people are aware of their status early and not late, and they will be able to link into care much earlier. While we have advanced, as I said, we need to incorporate and embrace different testing strategy. And of course, HIV self-testing was identified. And it is one of the areas still lagging in the region, but we are hoping that pretty soon, most of the countries will advance at different levels with HIV self-testing, because we have seen that during the pandemic, this is one of a critical testing modality that could continue this essential and critical service for HIV self-testing, both ensuring access and as well as the level from the service provider. And then I must add that we have to ensure that we strengthen testing of partners, and this could be both assisted and unassisted, strengthen and scale up community testing. And so once we can include and expand all these modalities, I think we will help to ensure that the testing is available whenever individual needs it, and for those populations that are very, very hard to reach. I would not go much into the issue of the pandemic, but I think the pandemic has showed us that when it comes to the testing modality, we have to have more than one modalities. And we are advocating here at PAHO for the HIV self-testing as a critical modality with linkage to care for all those who are HIV positive.
You know, I think we've seen with, as we said, there are lessons from the pandemic. We've seen where persons were hesitant to be tested for COVID-19. And then when community advocacy started and people went into the community and talked with people, people started to be vaccinated in higher numbers. So if we know that it works for this area, certainly more community, but I guess it is also a matter of the workforce available to do this at this time. So I hear you. I guess the self-testing right now makes the most sense. We're seeing rapid testing for COVID. So certainly we can have that as well. I really wanted to ask you though about the stigma. After all of this time, Sandra, is there still a stigma around this, not only in the general public, but around leaders? Is it still an issue? And we really want to encourage you to join the conversation by putting your comments or questions in the chat. Sandra, I hope I'm not putting you on the spot, but is stigma still an issue?
Of course, stigma continues to be an issue, and it's one of the a major problem that affect access to health services and access to testing services for key populations and for people who, for various reasons, it could be self-stigma or whatever the reason may be, the stigma affects individual for accessing the services. And if they're not accessing the services, they will not know their HIV status, and if they're positive, they will not be linked into care. So it is a very critical part of the HIV response.
I'm going to move now to you, Rosman, and the Pan-Caribbean Partnership Against HIV and AIDS. Can you tell me about the work that you've been doing before and even during the pandemic? How have things been going at PanCap?
Thank you very much, Lisa. Good morning to the panelists, and also good morning to everyone listening by Facebook. I think that as the previous panelists have said, that we've recognized that the pandemic has been very disruptive to HIV services. The Pan-Caribbean Partnership Against HIV and AIDS, PANCAP, as we know, is the regional coordinating mechanism, if I may put it that way, that brings together government, civil society organizations, bilateral and multilateral agencies, and even donor agencies, so that there is a coordinated response to the HIV situation in the region. Before the pandemic, we've been working to ensure that, as you've mentioned earlier, that the region is on track towards the elimination agenda so that we can end AIDS by 2030. However, with this pandemic coming on board, we have seen many situations that have disrupted the continuity of care because of COVID-19. And so with this, we've really been working with our partners to ensure that HIV still remains on the agenda. It is still a public health priority for us in the region. And so we've been working to ensure that these disruptions that have been spoken by the other panelists, such as disruption in testing services, disruption in treatment and care, and more importantly, disruptions in social services, because we have to realize that HIV is not only about biomedical services, and it's not only about giving antiretrovirals. There are other social services such as education, housing, income, and so forth that are so critical towards ending inequalities and ending AIDS in the region. So what we've been doing is that we've been working with partners, including national governments, civil society organizations, and even partners like PAHO to ensure that we put in place strategies so that we can end AIDS as a pandemic, but also we can end the current pandemic, because we know that that both the current pandemic and HIV are thriving on all of these inequalities in the Caribbean region. And we know that our region has a very wide inequality gap. And so with COVID-19, there is the potential that this gap is going to widen even further, and it is going to even put us off track towards ending AIDS. So what we've been doing is develop strategies such as safeguarding providers and users. We know that we want them to access safe services, and we don't want COVID-19 to be an obstacle for people accessing services. We also want have been working so that we can have them embracing new innovations, new practices such as HIV self-testing and PrEP, because we know because of the current pandemic, services have been closed or have been scaled back. But with that, that is really no excuse, because if you can't access traditional testing services, you can then use HIV self-testing as a way of knowing your status and being testing. We have also been working with countries to strengthen health systems. Sandra did speak about integrating into primary care, integrating into other services, because many of our countries have just a centralized HIV clinic. And so people have to move from one place to the other to access services. And as you know, Alexa spoke earlier about, difficulties in transportation and so forth. And so if you have these services being available in the community and closer to people, then the access becomes easier. We also have to put people at the center of the response, because what we've been seeing is that, a lot of strategies, a lot of response to the pandemic is focused on, ensuring that the virus doesn't spread, and that is good. That is what we have to do. We have to do as public health personnel, but we also have to think about the impact that is having on people living with HIV or people who are at risk. And therefore, you have to consider, when you put these measures in place, what measures we are going to put in place to ensure that people have access to services, that they're retained in care, and that they're taking, their medication. But also, we have to have a joint response. We have to bring together at the table, and we have been doing this as PANCAP. We've been bringing together at the table National AIDS Program managers, civil society organizations, people living with and affected by HIV, and others, so that we can have this frank discussion to really identify what are the obstacles that are preventing us from going forward, from really, moving at a faster pace, so that we can really get back on track towards 2030.
Thank you so much, Dr. Adams. And I think we have, like Dr. Gowani said, we have new tools, we have things that we can use, but there seems to be a little bit of a resistance when we talk about pre-exposure prophylaxis, when we talk about ART and U versus equals U, undetectable equals untransmittable. Is it, I'm coming to you, Alexis, is it that the stigma is what is driving this? Can you tell us about the impact of stigma and discrimination, specifically on U equals U in the Caribbean from your perspective?
Well, again, that message has to be disseminated to the communities, to the vulnerable communities, and to all communities. You're not just vulnerable, but U equals U is not pushed as much as persons getting their diagnosis and then getting virally suppressed. The messaging has to be direct. And we're not, I think, in my opinion, we're not using U equal U as an advantage for our Caribbean region. Some people look at it as a promotion of like I said, of immorality. And that is the barrier, and that's where the stigma comes in. And the stigma comes in most of all from our own clients, their internal stigma of who they are as individuals. And then contracting the virus adds another layer of stigma based on the religious dogma that that's what you were supposed to get if you're a part of that community, not knowing that anyone can be susceptible to catching the HIV virus. See, the messaging has to be, it's not having HIV is the problem. The problem is not doing anything about it. And I think for us, making that message clear to our clients that you can be undetectable, that you can reach a viral suppression load, has to be pushed within our community. It's not pushed enough. U equals U. Yes, if you are virally suppressed, you can become undetectable and you can be in a relationship. You can continue your normal life. You can live a healthy, normal life. But again, that messaging has to be clear and it has to be direct. And in my opinion, we're not doing enough as it relates to U equals U. And that's where civil society comes in, pushing that message that the government won't push, pushing that message that other agencies won't push. And that's where the collaboration comes in with our Ministry of Health and our persons on the ground within civil society.
I see lots of nods there. Someone else would like to say anything about that?
I guess I just want to add to what Alexis just mentioned, that civil society is a key in all this. They have a key role, and at all levels, we need to integrate them into the work to address HIV and to end AIDS by 2030. So I'm just endorsing what was just said by Alexis.
And Lisa, if I may come in, I think that Alexis made a very important point in terms of education and getting the message out there, because when you speak to people, they hear you equal to you for the first time, and it is not a new concept. And so I think that what we have to do is we have to try to see at all levels, maybe in the health and family life education curriculum in schools, maybe, you know, in the churches, in places, let people know that once you're HIV positive and you're retained on medication and you can reach an undetectable level, then you cannot, the possibility of transmitting is almost close to nil. And I think that with this can help us in fighting some of the stigma and the discrimination around HIV that we're currently confronting in the region. How do we get the message out there? How do we, reach the people who need to hear the message? Because many times we preach to people who know about it, but there are others out there who are left behind and they need to get this message. And so I think that as both Sandra and Alexis have said, civil society, this is where civil society comes in, because they intimately work with communities and with key populations and vulnerable groups. And so they can serve as a vehicle to take this message to those who really need it.
Now, I think my question around messaging, because I'm a communicator, so it seems to me like we need to have a campaign about this. But I remember working in HIV a couple of years back, and there was a lot of talk about not doing much general public messaging. Are we saying that we need to focus our messaging on vulnerable populations still? Is that where we need to put this messaging? Or is there still room for this for the general public? Anyone can answer that.
I think coming onto messaging, and I think Dr. Rosemont talked about getting services into communities, close to people, getting messages that are tailored, specifically tailored, because we cannot just assume that, we throw jargons that have been picked from different areas, and we assume that those jargons are going to resonate. I think we have to have customized communication strategies that targets people's specific needs. And I think this is something that needs to be done. And in the Caribbean, I would certainly agree. I mean, the work that the Knowledge Management Center that PANCAP is currently operating, that is jointly supported by PAHO and some of the partners, are doing a strong and credible job to be able to tailor specific messages aimed at specific individuals, because it's for communication, it's not a one-size-fits-all. And I think this is an area that we certainly need to strengthen as we move into doubling our efforts at reaching out those who are unreached.
Anyone else want to comment on that? Or can we move
yes. As it relates to messaging, we have to be very deliberate and direct. And the wording, again, there's too much, one, a political interference, two, there's religious interference, that it's stopping barriers from the messaging getting out there. It's too much, it's censored. And again, this is where civil society plays a role. What you can't say as a public officer, civil society can say. So again, that trust and collaboration with civil society is very important. That's the only way we're going to get it. Let's look at our prison systems in the Caribbean region. We have not addressed that vulnerable community within the prison system. And the rates of HIV in prison systems in the Caribbean, we're not talking about that. And how are we going to get this, achieve this goal? And we say leaving no one behind when we're leaving that community behind. So we need to be very serious and deliberate when it comes to our conversations as it relates to eliminating AIDS within our Caribbean region.
And I think perhaps it is that we're not focusing on the opportunities in PrEP and undetectable transmission. Like there are cost opportunities, it's greater acceptability, there's less stress on efficacy and safety. These are proven measures that can help. So why after 11 years of pre-exposure prophylaxis, is there still hesitance to recommend it? Is it that we're not saying the right things to encourage people?
Again, it takes political will. It starts from the top. Only the Ministry of Health can approve that. Permanent secretaries direct, that's where it starts at. The work on the ground is not so much the community, the community knows what they have to do. What's available is not always accessible. And that's the problem. They don't have the access to it because the tops are not approving it. A case in Trinidad and Tobago, perfect case and example. The heads, the decision makers aren't approving it. So our messaging needs now too to go to decision makers and gatekeepers. Even though COVID-19 has taken over the conversation, we need to get back. I saw something on social media. Oh, we don't have to worry about AIDS no more. We don't have to worry about cancer no more. We don't have to worry about NCDs no more. We have to worry about COVID-19. So the messaging is being lost within this whole conversation. But again, it takes the political will of decision makers and gatekeepers. And again, the government changes every 5 years. One government might be for it, the other government comes in, it's wiped away. And that's where we need to start working on. How do we deal with CARICOM? How do we put these things at the OAS level? How do we put these things as policy? So when a government comes in, it's not removed and it's not erased. And that's where we are. We need to stop preaching to the choir and get down to the congregation.
Well said. Well said.
If I may jump in, I think that this is a perfect case of messaging, because while we focus on reaching certain populations, it is also important that we focus on reaching our policymakers and that they understand this message, because they have to make a decision, and this decision has to be guided by the message that we send to them. Many times our policymakers' health literacy, the levels are probably not there. You come to us and we speak about PrEP, but they really don't understand what is PrEP and the impact that PrEP can have on the elimination of HIV and on reducing new infections, because we go with all of these technical terminologies and so forth. And so we need to tailor the message also to them, to convince them what can we do with these tools that are available and the urgency of implementing these, because if we wait too long, we will not get back on track to ending AIDS by 2030. The other thing is that as we try to convince our policymakers, I know that in our region there is always a lot of why not. We have to move away from that, because there's always if you do this, the focus on all of the negatives. And we've seen it with PrEP. I think Alexis did mention this, and we're hearing it with HIV self-testing. If you implement this, you're going to get XYZ, and it's all on the negative. We have to shift this around, and we have to show why, if we implement PrEP, if we implement HIV self-testing, these are the positive outcomes that we can get. So how do we reach and how do we convince the policymakers? I think it's a discussion that we have to continue having and engaging them throughout all of the discussions we're having.
Yeah. And if I could just add, it's an ongoing discussion. The simple fact that we are now talking about introducing PrEP in some countries that were not want to even hear the word PrEP, that is showing that as regional partners with the support of PANCAP that we are able to reach some of the policymakers. Yes, we need to do a lot more. We need to strengthen the dialogue. We need to strengthen the communication, and we need to strengthen the advocacy across the board. The HIV self-testing, it's been around for many years and we've been talking about it. It's incremental step, but how can we push this? And so as an organization like PAHO, we work closely with PANCAP to ensure that the communication, the dialogue, looking at the cost benefit analysis of implementing these critical evidence-based information, convincing policymakers that it works. And if we're supposed to reduce the HIV transmission in the Caribbean, these are the initiatives that we need to embrace, these innovations, prevention innovation. We have to embrace it in the region.
That's all right. There are innovations and there are cost benefits. Extremely good cost benefits for this. So I agree, and I sign up to help you with changing the messaging, so you can hold me to that. I mean, Dr. Bowani, WHO recommends immediate access, ideally on the same day, to HIV treatment initiation for HIV positive individuals. After everything you've heard, is this something that's feasible in the Caribbean? And what currently exists? Oh, I think Dr. Bowani is frozen. Dr. Bowani, are you hearing us? He's fallen off. Okay, Sandra, can you speak about that? Like, is that something that can work for the Caribbean? Dr. Bowani is back.
Okay.
Go ahead, Dr. Bowani. Did you hear my question?
No, can you repeat the question, please?
Sure, no problem. I was saying that WHO recommends immediate access, ideally on the same day, to HIV treatment for HIV positive individuals. Based on what you've heard of where we are in the Caribbean, is this feasible? And what is currently happening in the Caribbean?
Yeah, same-day treatment initiation is a viable option for Caribbean countries. This certainly reduces the chance of patients being lost to follow-up by immediately connecting them to care and starting the journey to an undetectable viral load. I just want to give an example of GESCO clinic in Haiti. The GESCO clinic in Haiti proves that same-day treatment initiation is possible even in the most challenging Caribbean country. GESCO clinics tested 41,000 people in 2020, and out of this 41,000, around 5% were found to be HIV positive and were immediately offered treatments. In 2020, GESCO helped about 87% of its patients on ART, and they were able to achieve the viral detection. So I think this, if you look at the case of GESCO, with all the constraints, we're able to do this. Most Caribbean countries have fully implemented Treat All, and the few that have not point to financial constraints. And again, I think they've talked about cost-benefit analysis and how to prove to our political leaders that, look, it's much more cheaper to put people on treatment rather than treating them. So certainly as UNAIDS and the coalition within the Caribbean, we certainly urge countries to take note of the opportunity costs. Untreated HIV leads to increased new infections. An investment in treatment today pays off with a lower disease burden in the future and therefore lower treatment costs in the long run. Community-led services are also a critical part of this activity and supporting diagnosed people to initiate care. We know that community health workers such as peer navigators play a critical role in this, that the healthcare service system cannot. They accompany clients in some cases to clinic appointments, address their concerns, and connect them to other mental health services, mental health and social support services. We need more domestic investments in the organizations and programs that provide these services in order to improve linkage to care and treatment adherence. As we continue the journey of implementing the 2021 2026 Global AIDS Strategy in the context of COVID-19. Renewed attention is required to address challenges around supply chain. I think we've been going through this, and I think there's been a strong emphasis in the Caribbean to work towards remediating the challenges. And we saw that during the COVID crisis. You know, we realized that in some countries, due to supply chain issues, there's been lack of treatment, and in some countries there's been oversupply. And so one of the things that we've been doing in the Caribbean is to work towards getting the solidarity where countries are able to connect and address the supply chain issues. Addressing these challenges in a proactive manner is critical, not only to sustaining treatment programs, but increasing patient trust and supporting their adherence. Let me add on this question to say, there should be a focus on giving people access to safe, well-tolerated drugs. We continue to urge countries to transition to TLD. I think PEPFAR has been very strong on this on the ground. PEPFAR and PAHO certainly. This drug combination provides health benefits. It's tolerated better than and has fewer drug interactions. People are more adherent because the regimen requires just one pill a day, and it's an extremely effective antiretroviral drug, which also lowers the risk of developing drug resistance. So yes, to a simple answer to the question, yes, this is possible, and we need to get we need to recommend easy, immediate access for all who need treatment.
I'm actually surprised by your answer because I thought it would have been a no. I thought we were not able to do it. So it's good to know that we can. I wanted to ask, just for my own understanding, are we at a position now where all countries in the Caribbean are practicing the treat all policy? Because I know there was a time where you waited until you got to a certain marker before treatment began. Are all countries at that stage yet?
I think all countries have systems in place. I think, again, a number of, and I don't want to mention countries, as a number of countries are still in the last mile of that, but most countries in the Caribbean have functionally gotten to the stage where the treat all policy is being adhered to.
If I could just add here, Lisa, yes, treat all policy, and it goes back to the whole issue of the messaging. I remember PANCAP and PAHO, we collaborated some years ago to do a cost-benefit analysis of what it would cost countries to do treat all or not to implement the treat all policy. And as UNA's quietly mentioned, is that yes, most countries are implementing, if not all, but there are different levels. So there are room for improvement, there are room for scale up, as well as for the transition to dolutegravir or the TLD, as was actually mentioned, because these are the newer drugs that is most effective. And I was very pleased when we looked at the analysis of the data for 2020 as to the number of countries that are transitioning to the new ARVs, but also we need to scale this up. So I think at different levels, these interventions are being implemented, but what we need to do is to scale up the intervention, strengthen and expand it across the region.
And I think there, in so doing, we would reduce not only the numbers of persons dying from HIV, but having not a good life, not being able to work, not being able to be, you know, valuable and productive members of society. If we look though at HIV mortality in the Caribbean, coming back to you, Sandra, how can we reduce HIV mortality in the Caribbean?
And this is linked to what we have been talking through the morning. It's linked to what we have discussed about the need to know your HIV status. What we have seen that individuals are sometimes diagnosed late during the state, they are diagnosed late in the HIV infection. It is estimated that 1/3 of the new infections are diagnosed late, and they have advanced stages of HIV infections, which means that the individuals may have CD4 counts less than 200, and they're in either stage 3 or 4 based on the World Health Organization classification. And these late diagnosis is always associated with a higher risk of ARV intolerance, and comes with it a number of health conditions such as the various opportunistic infections. 3 of the major ones I would talk about is the TB and fungal diseases such as the histoplasmosis and cryptococcus, which are 2 that we have been discussing this week. PAHO had a big regional meeting. We were emphasizing these 2 fungal diseases because these affect the mortality among individuals with advanced HIV. So therefore, it is very critical for us to have early diagnosis and linkage to care for treatment to actually reduce the HIV mortality. Therefore, we cannot overemphasize early testing and the emphasis to treatment, which are essential. In the absence of a cure for HIV, the introduction of ART improves survival of persons with HIV, but individuals also must adhere to treatment. If we do treat all or same-day treatment, it is essential that the individuals are adhering. HIV is now a chronic condition, and at times persons are experience fatigue from taking medication, or may need counseling to address some of their mental health conditions. How can we scale up these to ensure that individuals are adhering to their medication? The availability of ongoing counseling to address mental health issues and adherence to ARVs are also critical if individuals are supposed to stay healthy. The adherence to ARVs is associated with a higher chance of survival of the HIV-infected person. And therefore, we have to underscore that this is important, that we test and we actually provide treatment and appropriate treatment. We have the DTG that we know that when it comes to the issue of drug resistance, this is the gold standard drug at the moment. And of course, there are other issues, there are other barriers such as stigma that I would not go into. We have discussed it earlier, but stigma, those actually, as I had mentioned earlier, reduce the timely access to services. And these are things I have known, and I have heard reports of people refusing to go to health services because of stigma, and at the end dying from HIV, which this is something we should not be discussing at this day and age when we have the amount of knowledge and the medical interventions to reduce mortality at the moment. Yeah, thank you.
If I may just jump in quickly to this part of it, we cannot forget barriers with young people accessing services and being diagnosed at a very, very young age. In our LGBTI community, vulnerable communities, we know that parents throw their children out to the street based on their sexual orientation or their perceived gender identity. So they find themselves homeless, they find themselves sleeping on beaches, and they find themselves in survival sex. They get a place to stay, living with some older man or older person who has the virus and doesn't disclose their status to the individual. And at that very young age, they start to contract that virus. Yeah. So we need to be very, again, deliberate in our advocacy when it comes to ensuring people are tested. And when we say test all, we mean test all. But again, the barrier comes from the legislation. We can Girls can access consent to sex at 16, but they cannot access health services until they're 18 without a parent or without an adult. So these, we see that we have some barriers within our own laws and decision makers in the Caribbean region. How do we get the true conversation out of treat all and those that need access to services at that young age? Again, civil society plays a very critical role, especially in the Bahamas. In that role, we have to hire a social worker. So we need funds and we need resources in order to pay that social worker to be able to stand on behalf of that HIV positive youth who can't tell their parent that they are positive, who are thrown out on the street, who can access healthcare services or an HIV test until they're 18. So these are some of the things we need to really look at and consider. How do we continue the conversation of treat all and really meaning treat all and test all?
And if I could also add here, and thanks very much for actually bringing that to Alexis to the discussion, because there's so many dimensions to this particular topic, well, to all the topics we have been talking about so far. But I look at EMTCT, the elimination of the mother-to-child transmission of HIV, just the HIV component. We are saving the babies. Babies are being born free of HIV. And then, of course, because of prevention services that don't really reach the young people, as you mentioned, they are later exposed to HIV later on in life. And then we also have those who, unfortunately, were born with HIV for various reasons, and then they grow into adulthood, teenager, young adult, and then they have babies, and for some reasons along the continuum of care, something happened, and from what I have been, some of the data I've been analyzing, some of them refused to, or they stopped accessing service later on because of stigma. And the heartbreaking part of it is that you realize they die because of not accessing the services, stop taking treatment because they're not adhering. They got fatigued with taking medication, dying, and then leave behind young children. So it's a cycle, and we really have to continue this discussion that all aspects are addressed, because it's such a comprehensive and the topic and the implication cuts across all levels of our society.
Definitely. I think what I'm hearing from all of you is that we need to create an enabling environment to end AIDS. It's more testing, it's more and more innovative treatment. It is making policy changes so that access is easier, and then also the support that's needed for persons, particularly vulnerable communities. I think we've had a really good discussion. I think that persons will learn a lot from what we've talked about today. I'm going to give you all last words, maybe starting in order on my screen. So Sandra, last words from you.
I think my parting words would say, the bottom line, as a region, we need to utilize all the prevention modalities, including those for testing. Testing is the cornerstone for treatment. We need to test people to identify persons who are HIV positive. We link them into care effectively, treat them early, work with them, provide the appropriate counseling so that they could adhere to treatment, ensure that the supply chain is available. And let's not forget the laboratory component, which is critical, because if we don't include the lab, we will not have from the beginning the kind of result we want for the HIV testing. But to basically say all of these are critical, that works together to ensure that we will reach the overall goal of ending AIDS as a public health threat by 2030. Thanks.
Thank you, Dr. Adams.
Yes, Lisa, thank you very much. I think that we need to be mindful of the existing gaps, and we've spoken about them this morning. But as Sandra said, let us not lose hope. Let us work together as a region and be optimistic that we can end AIDS by 2030. We need to have more of these frank discussions that we've been having here today. And these discussions need to be all inclusive, from from the children to the adults to the policymakers, etc. Let us all be part of these discussions. Let us use the evidence that are available. Too often we go on emotions, we go on, as we will say in the Caribbean, on hearsay. Let us use the evidence and place the evidence on the table and use that to guide us in moving forward, ensuring that we have proper systems in place to monitor and to evaluate for success, and to put structures in place to ensure that health systems are strengthened. People are put at the center of the HIV response, and we really try to integrate HIV instead of looking at it as as a single disease. Let us look at the social determinants also that are impacting and influencing and preventing us from really moving forward with that speed that we need to move forward with to ending AIDS. And I think that once we're able to do all of this, I am really optimistic that we can get there and we can end AIDS by 2030.
Thank you, Dr. Adams. Alexis?
The messaging of leaving no one behind is critical. And leaving no one behind includes migrant communities, women, children, young people, LGBTI communities, persons even in church, persons even who we don't even suspect. Leaving that message of no one behind, we need to take that seriously. Treat all, test all. Getting them undetectable, that's critical within our Caribbean region. So if we really want to end this, if we really want to bring this to an end, I think for us, it's important for us to continue the conversation. And my closing word is we must continue educating. Education is important for decision makers, gatekeepers, and community members alike. That's the only way we're going to eliminate this, and we're going to end this by 2030.
Thank you so much. And finally, Dr. Bawani.
Thank you very much. I think from my perspective, as we move into the new AIDS strategy, I think there are three things that I want to talk about. I think in the Caribbean, we need to strengthen the capacity of civil society and communities to have tailored specific responses because they are the legs on the ground. And so I think all of us would need to figure out how we will strengthen, galvanize the capacities of civil society and communities to reach their, to do what they are supposed to do. The second thing I would think about is PANCAP. PANCAP is our lead regional, especially for the Caribbean. We galvanize and strengthen the capacity of PANCAP. We have a very strong partnership going on. And I think that the partnership must grow stronger and stronger. And we need the youth on board. We need communities on board to voice and come up with innovations. And I think so civil society, communities, the PANCAP network and innovative methodologies are going to be important if we are to be able to bend the curve in the Caribbean.
Thank you so much to all of my guests. I think we had a really good discussion. I think we touched on a lot of very important topics, and let's continue this discussion at some point, please. I'm going to ask my team to make sure they put the link to the website for the 2021 dedicated World AIDS Day website. There are lots of materials there. We want you to help us to spread the word as we strive to end AIDS by 2030. So I'm going to thank you so much for joining us. My name is Lisa Bailey, and until the next time, we will definitely be having another interesting Facebook Live conversation for you about another area of health. So thank you for joining us, and continue to enjoy the rest of your day. Bye-bye for now.